We presented data from our first-in-human phase 1 trial of the oral first-in-class covalent Werner helicase or WRN inhibitor, RO7589831, in patients with microsatellite unstable MSI and or mismatch repair-deficient or dMMR advanced solid tumors. The background to this is WRN is a helicase enzyme that belongs to the RECQ family and importantly plays a crucial role in the maintenance of genome integrity. And WRN also serves as a DNA caretaker enzyme, playing a critical role in unwinding non-canonical secondary DNA structures, such as holiday junctions, bubbles, and forked duplexes, that are formed in response to DNA damage or during DNA repair processes. RO7 is a first-in-class covalent WRN inhibitor, and this is important because WRN inhibition represents a synthetic lethal vulnerability and a genuine synthetic lethal opportunity from a therapeutic perspective in cancers with microsatellite instability. For example, we know that Werner helicase inhibition leads to an accumulation of DNA double-strand breaks and eventually to mitotic cleavage and eventually to cell death and apoptosis. RO7 actually engages covalently with a cysteine 727 that's located in an allosteric pocket of the WRN helicase, and this covalent binding locks the helicase in a single conformation, preventing it from transitioning to the subsequent conformational state that is critical for its helicase activity. And essentially, RO7 also exhibited potent and selective anti-tumor activity, including tumor regressions in MSI, CDX, and PDX models, providing the preclinical rationale to proceed to this first-in-human phase 1 clinical trial. This was the first presentation of the clinical data from this phase 1 study, and we use a CRM EWOC design for this dose escalation phase. We treated a total of 44 patients. The vast majority of patients, 95% of patients, had received prior immune checkpoint inhibitors. They were heavily pretreated with a median of 3 prior lines of treatment and up to 12 prior lines of treatment. Of the tumor types, we treated 52% of patients who had colorectal cancer, 47% of patients had non-colorectal cancers, including 7 with endometrial cancers. Overall, this was a very well-tolerated treatment with no DLTs and no grade 4 to grade 5 adverse events, and the preliminary safety profile is very manageable, with mainly GI toxicities such as nausea, vomiting, and diarrhea that were observed on treatment. Pharmacokinetics showed that RO7 was rapidly absorbed and eliminated with a half-life of 4.4 hours and a Tmax of 2.5 hours, and PK modeling showed that steady state was reached after 14 days. We also showed that the mean PK following the first dose increased dose proportionally. We showed promisingly that FDG PET scans demonstrated metabolic responses in 50% of MSI patients across all dose levels, and we showed a reduction in metabolic activity in 76% of MSI patients across all of the dose levels treated. And interestingly, we found that early metabolic responses during treatment were associated with RECIST partial responses and durable RECIST stable disease with a median duration of greater than 28 weeks. We also found RECIST responses. There were 5 partial responses across the different doses from 150 milligrams once daily up to 1,000 milligrams given twice daily. Out of the 5 partial responses, these were all durable responses. We also observed that 51% or 18 patients had very durable stable disease for a disease control rate of 65.7%. We observed very durable disease stabilization in a majority of heavily pretreated immune checkpoint inhibitor resistant MSI patients, And the disease control rate overall was 65%, and 28% of patients were still ongoing at the data cutoff. The median duration of treatment was 19 weeks. And these efficacy data was supported by ctDNA responses that were observed across the different tumor types and doses in patients who had achieved partial responses and stable disease by RECIST criteria. We observed significant ctDNA reductions in 57% of patients, and interestingly showed that early ctDNA reductions clearly delineated patients who had achieved RECIST partial responses and stable disease from those with progressive disease in ctDNA evaluable patients. So overall, we have shown that RO7 is a novel, first-in-class covalent WRN inhibitor for the treatment of MSI patients. We showed the first early clinical proof of concept for effectively drugging Werner helicase. And the most common AEs were very manageable with just grade 1 to 2 nausea, vomiting, and diarrhea. We found that the PK was rapidly absorbed and eliminated with a half-life of 4.4 hours. And it resulted in RECIST tumor shrinkage across the different dose levels and indications. And these efficacy signals were also supported by both metabolic responses and also molecular responses, as demonstrated by FDG PET scans and ctDNA studies, respectively. Dose optimization is currently ongoing with 3 randomized cohorts to establish the recommended phase 2 dose.